Good afternoon. The topic that we're about to discuss today is based on two major review articles that we published in OPRS journal in 2015 and 2016. I'd like to acknowledge my co-authors, particularly Dr. Yusuf Fuad, who did a tremendous job on both papers, and Dr. John Dutton, who did a tremendous intellectual job in the embryologic paper, and Dr. Muhammad Abdul Hafiz. I remember not so long ago that every time I was faced with a patient with a congenital defect in the eyelid or coloboma, and by the way, the term coloboma is restricted only, or its use is restricted only in the eye and its adnexa. No other area in the body, as far as I know, has this term. The coloboma means, in Greek, means a defect in tissue. This ocular colobomas are well known, but our discussion today will focus on eyelid colobomas, which were until recently, at least for me, a real enigma. An issue that was really confusing to me 10 or 15 years ago was that two patients, both with congenital upper eyelid colobomas, one of them might present at the age of 2 years with a perfectly normal cornea, while another one would present at the age of 2 days with an impending perforation and a corneal abscess. And I was always dismayed. What's the difference between this slide up and this slide down? Both have an equal size defect. The one is about to perforate and the other it's a perfectly normal cornea. The problem back then also is that when I tried to review the literature and try to find the systemic association with these colobomas, I was amazed at the sheer number of syndromes that are associated with upper eyelid colobomas. And at one point I counted maybe like 41 different syndromes, or at least at this point I thought they were different, describing patients with upper eyelid coloboma. But then it struck me at one point that after reviewing all the pictures of patients whom I encountered with upper eyelid colobomas, that they can be simply divided into two groups: colobomas associated with corneopalpebral adhesions, in which the cornea is adherent to the eyelid, and colobomas not associated with corneopalpebral adhesions, in which the cornea is totally separate from the eyelid. As you can see here in slide left, this is the type of coloboma, or the first type, which is associated with corneopalpebral adhesions, where a defect in the lid is replaced by abnormal skin. No eyelid tissue is here, and it's attached to the cornea. And this is the more dangerous type, and it's a true oculoplastic emergency. Whereas on slide right, you can easily see that the cornea is perfectly normal and that the eyelid is totally separated from the cornea. And this is the type without the corneopalpebral adhesions. And we decided to classify the colobomas into isolated or syndromic colobomas, depending on whether or not they are associated. Each type of those is associated with systemic changes or not, and then divided the isolated types into colobomas associated with corneopalpebral adhesions and simple colobomas not associated with corneopalpebral adhesions. And this classification was published in OPRS in 2015 and is available as an open access paper in OPRS journal. Again, a closer look at the literature has demonstrated that what we were mistakenly considering to be 40 different syndromes are actually 2 different syndromes. Actually, Golden Heart syndrome has 16 different names in the literature, while Fraser syndrome, the syndromic part of the eyelid colobomas associated with corneopalpebral adhesions, has like 15 or 16 different names in the literature. So like almost 100% of patients with syndromic eyelid colobomas either fall here in the Fraser syndrome category or fall here in the Golden Heart syndrome category. So we can simply remember 3 or 4 descriptions only: Fraser syndrome and Golden Heart syndrome for the syndromic types, And for the non-syndromic types, cryptophthalmos, or which is the type with the corneopalpebral adhesions, or isolated colobomas without the corneopalpebral adhesions. So I'll start by discussing cryptophthalmos or colobomas associated with corneopalpebral adhesions. As you can see in this illustration, there is absolutely no eyelid tissue either in the upper eyelid or in the lower eyelid. You can't see anything, as you'll see immediately now. It's as if the eyebrow skin has extended from the brow to the cheek. This skin is abnormal skin, has no skin adnexa, no tarsus, almost no eyelashes, and there is complete corneopalpebral adhesions. There are no stem cells in the conjunctiva. The cornea is damaged, although some of these patients may have perception or respond to vision. And in general, these cases are inoperable. Another case where you can only see a small dimple between an imaginary place where the upper eyelid is and the lower eyelid of the cheek, a small dimple with the 3 or 4 eyelashes only. That's about it. Another example, which unfortunately was operated upon several times, as you can see, there is complete failure of the surgery. These cases are inoperable. One could argue, how could this be considered a coloboma where no defect is seen? As a matter of fact, this is a case of coloboma because there is absolutely no eyelid skin. All eyelid skin is missing. The skin that you see in this case, which is naturally from a flap, but in the previous cases even, this is abnormal skin, which has nothing to do with eyelid skin and is totally adherent to the underlying cornea and conjunctiva. Therefore, it is a true coloboma. Another example of complete cryptophthalmos, it should be noted that most of these cases are associated with the syndromic form or Fraser syndrome, but sometimes they are seen in isolation. Another example too of a case of complete cryptophthalmos, and you can notice the absence of the nasal cavity on the left side. Another case also with the right complete cryptophthalmos and left partial or incomplete cryptophthalmos, and you can also notice the nasal abnormality, the abnormal shape of the nose. Incomplete cryptophthalmos is a milder form of complete cryptophthalmos, where the defect is almost total, but there is some part of the cornea that developed normally, as you will see. As you can see in this part, it looks as if the eyelid coloboma is small in this part. However, the actual size of the coloboma encompasses all this area, from here to here. All this is abnormal eyelid skin. Of course, no healthy conjunctiva under it, and no healthy corneal epithelium either. And this is also nearly inoperable. It can involve the lacrimal system or may not involve the lacrimal system, the puncti, may or may not extend to the lower lid, as we'll see in slides that will come later. Another example of incomplete cryptophthalmos extending into the puncti and into the lower lid. The entire cornea is almost adherent to the eyelid. The parents should be notified that the prognosis for useful vision in these eyes is very, very low. Another case of incomplete cryptophthalmos where the coloboma looks deceptively small, while actually all this part is the colobomatous part and is composed of abnormal skin completely adherent to the cornea. This is an interesting slide, an intraoperative photograph to show the difference between the normal eyelid with tarsus, as you can see here, and the abnormal eyelid skin of the colobomatous part, which is totally unhealthy, and the underlying side looks like subcutaneous tissue only, no tarsus, as you can see the difference, and almost 70% of the cornea is involved with the coloboma. The third and most common type, which is traditionally called the congenital symblepharon variant. The name congenital symblepharon is a relic of 19th century medicine and should be abandoned for the more proper name partial cryptophthalmos. If you look closely at this child, this baby, you will realize that actually patients with cryptophthalmos either complete, incomplete, or even partial. It is a continuum. Therefore, you can see some patients with complete cryptophthalmos on one side and partial cryptophthalmos on the other side. So it's a continuum. And even partial or congenital symblepharon can vary from severe cases where the abnormal skin that replaces the eyelid skin is adherent to most of the cornea, to cases, as we'll see later, which are much milder. And here, this child, for example, the left side is much milder than the right side. These patients may have normal useful vision if the corneopalpebral adhesions are mild. And as we mentioned earlier, this is operable and this is a true oculoplastic emergency. This child presented with bilateral corneal abscess and was operated on immediately at the age of 7 days. Another child was 2 weeks old, which was operated upon immediately. Notice on the other side that there is complete cryptophthalmos. Almost complete, because you can see, you can barely discern the lower lid here. You can barely discern it here. These cases can be bilateral or unilateral, mostly bilateral, but in this case it was strictly unilateral. Another milder case where the adhesions are involving only the peripheral part of the cornea. Another example with a minimal colobomatous defect of the left side, and this patient had incomplete cryptophthalmos on the other side, by the way. But if you evert the eyelid, as you will see in the next slide, if you evert the eyelid, you will see this little bit of adhesions between the colobomatous eyelid and the cornea. So it still qualifies as a patient with corneopalpebral adhesions, but still it's very mild, did not require surgery. Most cases of cryptophthalmos are sporadic with unknown etiology, probably resulting from a de novo mutation. But familial cases have been reported in the literature. The case could be made that cryptophthalmos is an arrested form of Fraser syndrome, based on the fact that within some families with Fraser syndrome, there are family members with isolated cryptophthalmos. Another possibility is that cryptophthalmos is a disruptive anomaly because two mothers in our case series were possibly exposed to a teratogen in early pregnancy. The first mother was accidentally exposed to X-ray irradiation with her elder son, and the second was a nail technician with long-term exposure to nail glues and nail gels. So it could be a possibility that it could be a disruption anomaly. As to what actually happens, or the pathology of what happens, if you study your embryology, you will realize that the eyelids fuse at the age of 8 weeks post-fertilization. And before that time, the cornea is fused with the eyelids. And only does the cornea separate from the eyelids when the eyelids are completely fused. As we all know from embryology, the eyelids remain fused from the age of 8 weeks till the age of about 20 weeks. They start to microscopically separate. So I think, and it's my own theory, that whatever happens in cryptophthalmos and Fraser syndrome happens during the process, is an abnormality of the process of eyelid fusion, where the eyelids are still adherent to the cornea. The second type of colobomas are colobomas not associated with corneopalpebral adhesions. They are either simple colobomas, non-syndromic, which are pretty rare. The more common variety is the simple colobomas associated with golden heart syndrome. The defect is usually rectangular, or if it's smaller, it's usually triangular, usually between the medial and central thirds of the upper eyelid. And as you can see here, a very interesting finding is that there is an abnormal ridge of tissue or thickening on the upper edge of the colobomatous eyelid, as if it's been operated before. It looks as if there is bumping of or thickening of eyelid tissue in this particular area. And this is a common finding in patients with golden heart syndrome, colobomatous defects, or isolated colobomas, this abnormal thickening or ridge of tissue. Another example of isolated coloboma with an abnormal thickening or ridge of tissue, again here, this case was neglected and therefore the cornea was scarred, and therefore this proves that the fallacy that patients with colobomas not associated with corneopalpebral adhesions can be left alone. They may be delayed a little, but it should be watchful observation, because if they are neglected, they will get a corneal ulcer, not as very early as cases with corneopalpebral adhesions, but they still get it. Another example of a patient with isolated coloboma who developed a corneal ulcer very early in life and had to be operated upon immediately. Another example too of isolated coloboma, which is rectangular in shape. Another example of a rectangular small coloboma, and you can again notice the abnormal thickening or ridge of tissue on the upper edge of the coloboma. Another triangular defect in the upper eyelid. Another triangular defect in the upper eyelid, which did not involve the cornea she presented at the age of 22 with a perfectly normal cornea. Isolated or simple colobomas without corneopalpebral adhesions represent an enigma. Whether they are an arrested form of golden heart syndrome or not remains to be seen, but what happens exactly will be discussed in the next slide. My theory, and I'm just hypothesizing here, is that the events that lead to isolated colobomas or colobomas associated with golden heart syndrome occur during separation of both fused eyelids at the age of 20 weeks. And this can be evidenced by the presence of the ridge or thickening that we see frequently, as if something happened while they're deplugging, both eyelids were deplugging from each other. Now we will discuss the systemic associations of both types of colobomas. I'll first discuss Fraser syndrome, which is associated with colobomas with corneopalpebral adhesions, and it has major features and minor features. The single most important feature is cryptophthalmos. And then in addition to cryptophthalmos, you can see in the majority of patients an absence of the eyebrow, an abnormal tongue of hair that is extending from the upper eyelid downwards into the lower eyelid. There is also this, as can be seen here, the abnormal tongue of hair again, and here again this abnormal tongue of hair. This case with an abnormal eyebrow in the on both sides. High arched palate is common in patients with Fraser syndrome, and an absence of nasal abnormalities. For example, an absence of a nasal cavity in one side is very evident here and here. Mucocele, therefore, is very common in these patients and in nasolacrimal duct problems. Ear anomalies are also common. The major non-facial features include talipes equinovarus and cutaneous syndactyly of the hands and feet, particularly of the middle fingers. Other findings are a positive family history, which is found between 40 and 60 patients. Renal abnormalities, including renal hypoplasia, renal agenesis, and urethral agenesis are very common. Ambiguous genitalia is very common, and respiratory tract abnormalities in the form of laryngeal atresia or tracheal stenosis are very common, and these patients should undergo general anesthesia with extreme caution. Golden Heart syndrome is a syndrome with diverse clinical features and conflicting reports of laterality, sex predilection, and etiology. But it is interesting to note that despite all these facts, there exists a mandatory feature of the disease, which is the presence of pre-auricular skin tags. This is present in between 95 to 100% of patients. Also present are flattening of one half of the face and marked facial asymmetry, or what is called hemifacial microsomia, and is caused by an underdeveloped mandible, maxilla, and zygomatic bone. Also, of course, the major ocular feature is limbal dermoid. A dermolipoma or lipodermoid is also frequent, and an upper eyelid coloboma, the simple type, is usually encountered. The basic principles guarding the management of the cases of congenital upper eyelid colobomas differ slightly from the basic principles that we use in management and general reconstruction of the upper eyelid. I think by now, at this point of the presentation, we will realize that there is nothing that cannot be understood, that this case in which there is a corneopalpebral adhesions is a true oculoplastic emergency which needs to be operated upon immediately, bearing in mind that if it is a case of Fraser syndrome, we might get into trouble with general anesthesia, while these cases in which the eyelids are not adherent to the cornea, we can observe cautiously. But if the first sign of a corneal ulcer due to exposure is found, we should operate and intervene immediately. The one advantage of this type is that because the eye is not adherent to the conjunctiva, Bell's phenomena is present, while in the upper slide with corneopalpebral adhesions, the cornea is adherent and no Bell's phenomena is there, so this eye is fixed to be exposed to the surrounding and getting a very, very rapid corneal ulcer. So this is the true oculoplastic emergency when corneopalpebral adhesions are present. Although very small defects can lend themselves to direct suturing with or without cantholysis, I'm not a big fan of direct suturing in children or babies with upper eyelid colobomas, particularly if the age is very young. Because when you operate at this young age, I mean, if it's a very small coloboma, direct suturing would suffice and would get excellent results. But if the coloboma is bigger, the problem is a little bit different. First of all, when you operate at this very young age, tissues are very stiff. They lack the elasticity of eyelid tissue that we encounter in older patients. And therefore, when you do direct suturing, especially if the defect is a little big, and even you can get away with canthotomy and cantholysis, but you get severe ptosis in the first few weeks, which is potentially amblyogenic and hindering the advantage of direct suturing over lid sharing procedures redundant, because in this case it is also amblyogenic. Also, because the tissues are very stiff, I've experienced several cases where the sutures ruptured in the first couple of weeks and had to re-interfere again and do a lid sharing procedure. So I'm generally warning against direct suturing in very young children, except if the defect is small. Another example of spontaneous suture lysis that also was encountered in one of my patients, and had to resort again to lid suturing, to the lid sharing procedure. Another disadvantage in my experience of direct suturing, besides ptosis and the possibility of spontaneous lysis, is that my impression is that there are no conjunctival stem cells in the upper fornix, and there are no there are not even healthy epithelium in the upper fornix in these patients with corneopalpebral adhesions or cryptophthalmos or Fraser syndrome. And therefore, by doing a lid sharing procedure like cutler beard from the lower lid and advancing normal healthy conjunctiva from the lower lid to the upper lid, you are advancing conjunctival stem cells into the upper fornix and the cornea. In my experience, this limits a little bit the extensive adhesions that you can see after the direct suturing. I'm here restricting my talk about patients with corneopalpebral adhesions, cryptophthalmos. I'm a big fan of lid sharing procedures in these cases, and although they could be potentially amblyogenic, as we outlined earlier, even the direct suturing can be amblyogenic in this case. The tarsal switch procedure may also be employed, but I have very little experience with tarsal switch procedure. My colleague, Dr. Muhammad Abdul Hafiz, has a better experience in tarsal switch procedures. Yes, you can get some lower lid retraction with the lid sharing procedures, but you manage to save the vision, and the symblepharon or the congenital symblepharon or the adhesions in these cases are kept at bay. This is just my theory, and it's not substantiated by any scientific evidence. This is just anecdotal experience. And just this morning, while I was preparing this talk, I came upon this paper which showed or substantiated my theory that the conjunctival stem cells are predominantly located in the medial canthal and inferior forniceal area. So it could be true that my hypothesis could be true, that we are transferring stem cells, and this could be helping a little bit to just a little bit reduce the scarring and the adhesions. Just a little bit, and it's just a theory. I'd like to thank you very much for bearing with me this boring talk. I hope it would benefit you in your practice. Thank you, and bye-bye.